Recruitment becomes more difficult if the treatments received in different arms of a trial are obviously very different. It's harder to recruit people to a trial comparing an invasive and a non-invasive surgical technique than to a study where the treatments were equally invasive. It can be harder still to recruit people to a study which compares a surgical technique with medical management. This is because when available treatment options are very different, healthcare professionals and patients are more likely to have strong opinions on which one is more suitable. The PROTECT trial compared radical prostatectomy, radical radiotherapy and active monitoring, three very different treatment strategies for prostate cancer. They also carried out qualitative research looking at the way information was given to patients. They found that the way information was given affected a patient's understanding of clinical equipoise and randomization. People who appreciated the idea of clinical equipoise and the need for randomization were more likely to recruit to the study. In this film, we talk to Pete Holding, Claire Kennedy and Derek Rosario, members of the PROTECT team, about recruiting to a surgery trial involving very different treatment strategies. Sometimes there is a genuine uncertainty amongst healthcare professionals about which way of managing a disease is the best. This is known as clinical equipoise. It can be hard for patients to understand that healthcare professionals don't know which treatment is best for them, and so why we need to do research. The issue has to be approached sensitively. Most of the time, healthcare professionals who recruit to a trial are in clinical equipoise.
I would genuinely stress the uncertainty at this point that I really don't know which is better. There are these, there is this, there is that, and I genuinely do not know which is better, which is why we're running a study on this. And it's useful at that point to put in that enough people believe that there's uncertainty to have put money into this study, and therefore we really do want the answer.
Even so, we have to be careful we do not seem to be conveying preferences for one treatment or another. We can do this unwittingly through the time and emphasis we give to each treatment in conversation, as Derek Rosario explains.
If you use terms like firstly and secondly, the patient may well pick up, hang on, firstly means that's the one, and often when you find people delivering these, that's the one that they prefer. And so, although they feel they have equipoise, in a subtle way they've conveyed some sort of prejudice to the patient without meaning to at all, and it really is very difficult not to. So some form of being more self-aware, some form of saying on the one hand and on the other hand, which is much more equipoise. So on the one hand there are these treatments, on the other hand there are those treatments, and we really, one of the dilemmas that we have is we don't know which would be best. If you tend to skate over something, often you're giving this unconscious thing that actually I don't really care much for that. But let's now come to the thing I'm really interested in, which is the HubBLe procedure, for instance. It's had some positive reviews, and that's why we're doing the study in it. Of course, there is rubber band ligation, but if we come back to the HubBLe procedure,
we need to talk slowly, stopping at regular intervals to ensure that the patient understands what's being said.
I found what's useful to do is to slow down and deliver them slowly, because you can often tell whether someone is, by the change of expression on their face, have they really heard what you've said, or have they suddenly thought, oh hang on, have they picked up something I didn't mean to convey?
It is also important to understand any preferences about treatment that the patient may have, to make sure that they are well informed.
You know, that's perfectly all right if you prefer X. Could you tell me what it is about it that you like, or what it is about it that makes you dislike the other one?
Sometimes the patient may prefer a treatment because it will leave them fit to return to work earlier, or because they would rather have a less invasive procedure. These are well-informed reasons which indicate that entering the trial is not the best course of action for the patient. However, sometimes they may have developed misconceptions about the trial or study treatments, which are worth challenging as part of a fully informed clinical consent process.
The process of informed consent was vastly improved from anything I've ever done before in my life, because we were giving people lots and lots of information before they came to this appointment. in normal circumstances, you would just take a patient's, decision as, okay, let's just go for it, because you've already given that information. We were actually exploring the reasons for that and correcting any misinformation, which was quite an unusual thing to do.
It's also very important to be clear about what treatments are available for the patient's condition at your trust, but which are not available as part of the trial.
One of the issues that we had with our study is that there were actually, outside of the context of the trial, other treatments, and we made a very clear point of making sure that the patients were fully informed of those treatments as well, because that again instills trust. I think if we had not let them know about those treatments, then they'd have had some suspicion that we're trying to hide something from them.
When we examine patient preferences, we are improving the process of informed consent for clinical treatment if the patient remains outside the trial, and for participation if they consent to enter the study. Far from being coercive, the PROTECT team believe that gently challenging patient preferences ensures that decisions are not made on the basis of misinformation. It is in fact the ethical thing to do.
Regardless of your decision, you will continue to receive the same standard of care in this department with the same people. So to try and remove this feeling of pressure that you take and that coercion into research.
The purpose and process of randomization is often hard for people to understand. A key piece of background that is often omitted is that randomization is there to ensure that the comparison of the treatments is fair. Here's how Derek Rosario explains this.
I often said we need, in order to try and determine which of these treatments is better than the other one, or what the difference is sometimes a better way to say it, between these two treatments, we need similar groups of patients in both arms, and clearly if you chose, or if I chose, we may end up reflecting those choices. What we need are similar groups.
The next key piece of information is that participants in the trial have an equal chance of receiving each treatment.
We need to emphasise that they have an equal chance of receiving either of those two treatments, and that's essentially what randomisation is in a nutshell, isn't it?
One way of explaining what randomization actually involves, which is accurate and honest, is that it is like a flip of a coin or the roll of a dice, but it is done by computer.
We could theoretically do it on the throw of a dice. And if you get an odd number, you go into one group, you get an even number, and that's starting to give someone, the idea of a random event. And you say, of course, these days we have computers, and then you go into the nature of randomization.
It is important to understand that both of these elements, the play of chance and the use of computers in decision making, can put some people off the research, as they can seem to trivialise the decision or convey a feeling that no one is in control. So, before asking the patient if there are any questions, it's important to reintroduce the issue of equipoise. Claire Kennedy and Pete Holding end on a high note, putting randomisation in context by stressing that, if the trial wasn't there, they wouldn't be able to tell someone which treatment was best for them.
We used to have to explain to them that they did have to be open-minded to all three treatments, because otherwise there'd be no point in randomising it. It wouldn't be scientific. So they did have to be definitely open-minded to all three, but that they were allowed to maybe be a little bit prejudiced towards one, but they did have to accept that all three of them would be something they'd consider at the end of the day.
I think it was important for them to take a step back from the study and actually put them into the context of, if this study wasn't going on and you'd been diagnosed with localised prostate cancer, what you would have is you'd be given information about these three treatments, and you'd then have to go away and make a decision about which one you felt was best for you. Now at the end of that decision, we wouldn't be able to tell you whether you'd made the right decision in terms of which treatment is best. So by randomising, in terms of risk, there's no greater or no less of a risk. The treatments are exactly the same. It's just the method of actually choosing them that is different. And for a lot of men, that actually helped them out of a dilemma, because they were really not sure what to do. It was very, very confusing to them. And by having the study actually do a randomisation meant it took the responsibility away from them. And they felt that was actually a helpful thing. We were wanting to make that decision based on an individual, informed, an autonomous decision, basically. And we wanted them to view that randomisation as basically as a good thing, as a helpful thing.
Immediately before consent is the moment to stress that patients are always in control of their situation. They won't be forced to do anything they don't want to do, and they can withdraw at any time.
The general standard of care that they would receive in or out of the study would be very high, and that they would be safe either way, and it is their decision at the end of the day. I think one of the things that's important to convey to the patient is that even though they're being asked to randomise to a treatment, they are actually ultimately still in control of what happens to them, because they do have the final say as to whether they actually go along with that randomisation or not. So I think it is important to make them feel comfortable and certain that we're never going to force them into anything they don't want to have done, and that they will always have the final say, and they are actually in the driving seat at the end of the day. And I think that does empower them to then allow themselves to be randomised without any fear of being coerced into something that they're not happy to have done.
I think you're absolutely right there, Claire. You know, this thing about saying to them, you are in control. The sort of words I'd use was, regardless of whether you take part in this study or not, you will receive the same standard of care in this department. You will continue to be treated in this department. So we've tried very much to integrate the research and the clinical pathways as in the care in this department. So the fact that you're on a research pathway or on a clinical pathway, it's all-encompassing care. The balance is trying to get them to see that that research pathway is within our care environment. And I think people may come to research and think, oh, does that mean, because they form a relationship with it, if I go into research, does that mean I step outside this? And that would be the only thing that I would therefore put research in a positive light, to try and offset that, to bring it back to research has positive benefits. So I can see how it could come across as being coercive, particularly if you say that their standard care is poor or research is much better. And it's getting a balance that actually, you know, regardless of whether you go into the research or stay with standard care, you will get the same standard of care within this department by the same setup.
By the time you deliver the treatment allocation to the patient, they should have been fully informed, had the chance to ask all necessary questions, and will have consented to participate in the study. The participant has entered into the research freely. For this reason, finding out what will happen next should be a positive and affirming experience, not one which raises doubts about the decision. Clearly, if the participant appears distressed or anxious about their allocation, then the informed consent process has not been successful. Their feelings should be explored immediately, and they should be reminded about their right to withdraw. Otherwise, it is important to tell the participant what will happen next and to invite questions about what the treatment allocation will involve.
Well, I think that the natural reaction from nurses is to say, and how do you feel about it? Now, we've already had that conversation before we did the randomisation. That's when all those kind of feelings towards this or values about this and do they understand the information, that's when those issues should have been addressed before they actually consented to be randomised. So to have that discussion after the randomisation has taken place just completely messes up the whole system. It confuses patients, and it means that you often don't get the outcome that you wanted. The best thing to do was to actually deliver it in a very positive way. So say they got radiotherapy, we'd say the randomisation has been radiotherapy. We can arrange to see the oncologist, in the next couple of weeks, and close at that point.
Because we start off at the outset by stressing uncertainty, aren't we? And you stress uncertainty right to the point of randomisation. But at the point that a patient decides to randomise, there's no more any uncertainty.
Fully informed patients should know that a trial is being offered because we don't know what the best treatment for them is, and that it's suitable for them if they don't have strong preferences. They should understand that the research will only be a fair comparison of treatments if we randomise them. Above all, before they consent, they need to know they are always in control of treatment decisions. After consent, the allocation of the treatment should be a positive step forward for the patient.